Well, let's get started, everyone. Welcome to the first renal biopsy conference of Rush University Medical Center for not only the new year, but I think it's the new decade. A lot's happened in the last 5 days. We've survived a coup in the United States. And more importantly, will the fellows survive the wheel? Because this is the starting of the new year is when we put the first year fellows' names on the wheel. If we can bring that up, that would be kind of nice.
There we go.
There it is. So now we've got Asim, Nurali, and Faraz on the wheel. Will the wheel pick them today? That's the big question. We ought to have bets on that, actually, with odds. That would be a lot of fun. Make some money. Today's case will be presented by Dr. Zhang. As usual, the patient has been de-identified and the dates have been changed. Today's CME activity code is 481291. It will be recorded. It'll be available on YouTube in a week or two. Please subscribe to our channel. That way you'll know when the new cases have been posted. Everyone will be muted by default except the faculty. If you have any questions, stick them in the chat room and we'll try the chat board and we'll try to address them. And as usual, we have nothing to disclose. So let's get started on the case. Roger, you're here.
The patient is a 35-year-old Black male with no known past medical history, who presented to Rush with an elevated blood pressure. He initially presented to cardiology clinic for evaluation of palpitations and chest pressure. His blood pressure in clinic was noted to be 222/148 and was therefore sent to the emergency department. He was started on a nicardipine drip and admitted to the ICU. His labs was notable for a potassium of 3.3, a serum creatinine of 3.4 milligrams per deciliter. He had no prior baseline creatinine values, but he denied any history of kidney disease. His UA was significant for 3+ protein, 3+ blood, 131 RBCs. He endorsed a 2-week history of daily ibuprofen use due to a back injury. He denied any other over-the-counter medications, supplements, or any illicit drug use. There was no recent sore throat. He denied gross hematuria, rash, fever, chills, arthralgias, or hemoptysis. His serum creatinine continued to increase and it peaked at 6.5 milligrams per deciliter with a BUN of 104. He was non-oliguric. He was started on pulse solumedrol 1 gram IV Q day for 3 days for concerns for an RPGN, followed by prednisone 60 milligrams per day. For Reveal systems, initially he was positive for chest pain, palpitations, and dyspnea. Otherwise, Reveal system was negative. For past medical history, he had no known past medical history. Social history, no smoking history, no current alcohol use, denied any drug use. Family history, he had an aunt who had end-stage kidney disease due to diabetes and hypertension. For his allergies, he had an anaphylactic reaction to shellfish in the past before. Medication-wise, the only one he was taking was ibuprofen daily for 2 weeks prior to admission. He was not on any other medications. In terms of physical exam, his initial blood pressure was 222/148 with a heart rate of 118, temperature of 98.4, respiratory rate of 18. His weight was 166 kilograms with a BMI of 49. He was saturating 99% on room air. On exam, he was awake, alert, and was in no acute distress. A retinal exam was not done initially. He had moist mucosal membranes without oral lesions, no cervical lymphadenopathy. He had no increase of work or breathing. His lungs were clear to auscultation bilaterally. His heart rate was tachycardic but regular. There was a loud S4, but no murmurs or rub. He had no lower extremity edema initially, and there was no rash. For his labs, his CMP initially had a sodium of 134, potassium of 3.3, chloride of 97, bicarb of 25, BUN of 33, and a serum creatinine of 3.4, a glucose of 90. His total protein was 9.3, albumin of 3.7, calcium was 10.3, ALK phos was 94, AST 22, and the ALT was 19. His LDH was 180, which was normal, and his haptoglobin was 130. His CBC had a white count of 11.8 with neutrophil predominance, hemoglobin of 15.1, hematocrit of 48. His platelet was 371. There were no schistocytes on the peripheral smear. In terms of his autoimmune studies, his ANA was negative, NT double-stranded DNA was negative, C3 at 158 and C4 at 42.5, both were normal. ANCA, ASO, anti-SCL70, SPEP, and UPEP were pending. In terms of ID, he was HIV negative, HCV antibody negative, COVID negative, but reportedly he had a COVID antibody tested prior to admission that was positive. For his urine analysis, he had a specific gravity of 1.014, pH of 6, 3+ protein, 3+ blood, negative glucoside-esterase, negative nitrite, 131 RBC, 7 WBC. His urine protein creatinine ratio was 2.6 grams per gram. Our urine toxicology was negative for any illicit substances. He also had a chest X-ray.
That on.
It was read as mildly increased, mild volume overload, but he also had an enlarged cardiac silhouette, which was unusual for patient's age. He had an echocardiogram that was read as left ventricular cavity was normal in size. However, wall thickness was markedly increased. He had an EKG that showed sinus tachycardia, but also had biatrial enlargement. A retroperitoneal ultrasound with duplex was done. It showed unremarkable bilateral main renal arteries. Both kidneys were normal in size and echogenicity. Patient underwent an IR renal biopsy.
All right. So we'll go for questions for Dr. Zhang. I actually want to start off with one, and that is neurologic exam. Were there any neurologic features like slurred speech or disorientation? It says he's alert, but I just wonder if there's anything that points to any kind of neurologic manifestations with this kind of hypertension.
No neurological deficits at all.
And then the other thing I was going to ask is, he has no recollection of ever being hypertensive?
No, he was not on any medications, at least he was not aware of being hypertensive in the past.
But yes, his echo shows markedly thickened left ventricular wall, so it sounds like he probably had a lot longer than he was aware of.
Probably.
He hadn't seen a physician. He didn't remember seeing a physician since he was a kid.
No, fair enough. But like I say, the echo becomes very helpful in that situation, I think. Bill, anybody else have any questions? All right, Dr. Whittier, why don't you start us off?
Sure, thanks. This case could go in a lot of different ways, I think. But when I hear about a 35-year-old Black person who comes in with an elevated blood pressure, and I see that they get admitted to the CCU for a cardine drip, I really think about hypertensive emergency, whether that's primary from like a thrombotic microangiopathy and causing, starting off with renal vasoconstriction, or whether it's even secondary, like a nephritic syndrome that comes in with hypertensive, is really where we need to, I think, delve into this a little bit more. So in Chicago, we see a lot of this population where it's a young Black population with hypertensive emergency, and they have renal failure from that. They often have renal failure from a thrombotic microangiopathy. With that, we typically see thrombocytopenia, we'll see a microangiopathic hemolytic anemia, we'll see schistocytes, we'll see a low haptoglobin. And so even though he presents like that, his CBC is remarkably unremarkable, meaning there's no thrombocytopenia, there's no anemia, she has no schistocytes. And for, at least at our institution, to have a peripheral smear that says no schistocytes is pretty impressive, because every time I've looked at a smear or seen the report of a smear, it always says mild to moderate, even if there's no, that's not even in the differential. So there's either some gamesmanship here, and we're really meant to go away from that, or it's that the abnormalities of the CBC have not yet been apparent. And we often do see patients on admission having platelets of 370, but then the next day they're 150, the next day they're 90, and then you start to see the abnormalities later on. Even as the blood pressure is controlled. What also goes along with that is hypokalemia. For you to have significant hypokalemia with AKI certainly would be unusual, and that to me means that there's a presence of quite high aldosterone, not necessarily from a primary hyperaldo, I'm not suggesting that, but just from this whole renal vasoconstriction, clamping down, causing a high renin, and a high aldosterone leading to hypokalemia upon presentation. So
No, but that's a good point. I mean, here's a guy that's coming to hypokalemic, first time hypertension, renal artery stenosis has been ruled out, but things like FeO and primary hyperaldosteronism, I think still have to be in play here at some point, right?
Yeah, and I think sometimes a renin and an aldo level can be helpful if it's, if the aldo is high, the renin's low, then that might point you towards primary. If they're both high, which is, when I check it, is universally, they're typically both high, then we think about that sort of renal vasoconstriction or clamping down as the primary event, almost like a scleroderma. Although in this case, of course, we have no clinical stigmata of scleroderma, although his SCL70 is pending. So I still like that, even though his CBC is so unremarkable as a TMA. And what we would see on the biopsy, well, if it's been going on a long time, just as the LVH in his heart is significantly there, that I would worry about onion skinning, vascular disease. You might even have some focal and global glomerular sclerosis, which might lead to the relatively high proteinuria that we see there, a little higher than someone we would expect from a vascular phenomenon. So what else could it be, though? I mean, there's a lot. I mean, he still has hematuria, he has proteinuria, and maybe that's the primary event, and he's hypertensive because of a nephritic syndrome. He's got a secondary serologic workup that's negative, so it doesn't really appear that it would be lupus or vasculitis. Oh no, the ANCA's pending, sorry. But his complements are normal. So I would typically think of an RPGN situation. We think of vasculitis, lupus nephritis. Could it be a COVID collapsing at FSGS? Certainly, all those are in the differential. Even an MPGN pattern, although his complements are normal, I think that's all in the differential as well. The last part of this that I would think that needs to be discussed is that if it ends up being the TMA from malignant hypertension, there is a little bit of a literature showing that because this happens quite frequently in Black patients, that there may be a familial predisposition to a primary atypical HUS or complement pathway problem, and the hypertension could be the second hit that puts them over the edge into the renal failure. So some are suggesting, even if we get to that eculizumab might be indicated. And some, of course, are suggesting that it is not yet indicated. So I think
holy shit, we've already jumped to therapy.
I think that's something we'd have to tease out if we do in fact have a TMA on biopsy. So all of that was a long way, long differential, but I think my number one, despite that great CBC, is still going to be a TMA.
All right, Casey, what do you think?
I think Bill knows his stuff. I really don't have a whole lot to add. I think, this young person with, a combination of nephritic, I usually think of FSGS. This whole COVID thing is interesting, that he's COVID antibody positive, which means he had it and maybe he just developed the collapsing FSGS from his COVID, and now we're just kind of catching it at the tail end of it when he finally comes in with significant enough renal failure that his hypertensive, and he comes in with the emergency, and we're seeing the sequelae of COVID associated nephropathy, COVAN, so to speak. So that to me is kind of an interesting diagnosis. TMA is definitely way up there on the differential. If anytime somebody comes in with a 222 over 148, that has to be on the differential, especially since his creatinine is just going up so fast. Like he went from 3 to 6, it seems like in a few days. So those are all very good differentials. Bill mentioned, MPGN, IgA, lupus. The lupus, obviously, ANA is negative. So those are all in the differential. I don't really have much to add, but I think my top two would be TMA and then FSGS, possibly either primary FSGS or a secondary collapsing from a potentially recent past COVID infection.
So what about the NSAIDs? Has everybody just discounted the NSAIDs as being a factor here, or?
Yeah, I mean, just too much proteinuria. I mean, you can get minimal change disease from NSAIDs, but then the renal failure, I suppose, could be ATN in the setting of minimal change disease, but then there's too much blood. The other factor would be interstitial nephritis, which explains the AKI, but then there's too much proteinuria for that. So yes, the NSAIDs could have essentially confounded all of this. But if you look at, 3+ protein, 3+ blood, the NSAID thing doesn't totally fit, but absolutely, you're right. I mean, I think Bill also mentioned that too, but I agree. The NSAIDs could also be contributing.
Yeah, I mean, when you've got this kind of renal failure, you're not going to have that much proteinuria until they open up. And then I've seen this in my own, all of a sudden they open up and the proteinuria is 20 grams. But it's just something that's after, saying he's been taking it for at least 2 weeks daily, it could easily be a factor. But I agree, a lot of the microscopic hematuria, he's got a lot of hematuria there for at least NSAID alone, AKI. I think it's also interesting, as Bill kind of alluded, the guy's got a normal CBC. And not only is the CBC normal and there are no schistocytes, but the haptoglobin is completely normal. I mean, it's not even close to being low. And as Bill already pointed out, the LDH isn't low. So there's no real evidence of any intravascular hemolysis like you would see with somebody that has some sort of malignant hypertension associated, whatever the cause may be, scleroderma, FEO, HUS, TTP, whatever category you want to throw this into. A lot of things don't really fit well. I mean, it's kind of interesting. It'd be great. You'd really like to see a low haptoglobin, a higher LDH, no matter what the cause of a TMA would be. You would hope to see that, especially with malignant hypertension, which is really what this guy's got. The only thing that we don't have is this retinal exam. And, if he had papilledema, it would really be perfect, and that's why I was asking about the neurologic manifestations, because it's not uncommon. I mean, papilledema is just a manifestation of the CNS involvement with malignant hypertension. But clinically, these people have slurred speech and other things that help point towards that. So a lot of things that are interesting, but nothing really fits together perfectly.
Steve, why do you say he has malignant hypertension?
Well, anytime that, in the old days, it used to be a diastolic over 140 with papilledema. That's why I say if you had papilledema, then you could use that term. Hypertensive urgency is an easy cop out. I mean, that's clearly what he's got. But, historically, my recollection was when the diastolic was over 140, I forget if the systolic had to be over 220, and they had papilledema or any neurologic manifestations. Usually, I don't remember that you had to have any hematologic findings per se, but hypertension to that level and papilledema, again, it's been a long time, but that was what we used to categorize it as.
Well, we did, but we've all seen our dialysis patients come in with that number and feeling fine. And I think that I'll go into this a little at the end, but I think it's not about a number anymore. So that's
I understand that.
And we don't have eye findings and we don't have schistocytes, et cetera. So I'm not sure you can actually say that.
Well, I said, if we had the eye findings and you had papilledema, then I think you could put it in that category. I think it's something you have to consider, though. Dr. Rubin brings up an issue about the globulins being high because the total protein is 9.3 with an albumin of 3.7. So there is definitely what looks like an increase in at least globulins. Mario, do you want to expand on that as to how you think that plays into this?
And the calcium's a little high for his degree of renal failure as well.
Yeah, you wonder if he's a little volume contracted from this severe hypertension, which can sometimes happen, which you alluded to with the hyperaldo type situation leading to hypokalemia, and they can sometimes be volume contracted. Mario, do you want to give us some thoughts as to?
Thank you for unmuting me. These new entities under the MGRS complex are quite interesting. I mean, some of them have quite a bit of endothelial injury, therefore could potentially in turn lead to this big-time hypertension. I mean, myeloma in a young person has also been described, but suffices to say that Roger just said that the total protein was elevated on admission, but then it came right down. So perhaps the patient was hydrated, and that accounts for the decrease. And we'll see what the SPEP and UPEP that are pending shows.
Fair enough.
I think it's a great point, though, and it actually went by me because when you put it in there, I thought it was probably a typo, and I went back and pulled up the chart to make sure that it was actually 9.3 because that was a huge gamma gap, as we call it. But I went back and it came down fairly quickly, so I don't have a good explanation necessarily, but it should not have been ignored exactly.
Yeah, and an interesting thing is, paraproteinemia is somebody under the age of 40. Paraproteinemia rate-related renal disease, as you alluded to, Mario, is pretty uncommon. It's like less than 1%, but it's I guess still possibility is something to be thought about, especially when you see a total protein that high. And as Bill alludes to, the calcium was on the upper end of normal as well. Pravir, you want to give us the final word?
Yeah, no, I think, you know, it's the way it's written is wonderful, because the presentation is it's broad, but, you know, I think putting the weight on the urine, and, you know, he has an active urinary sediment with the creatinine going up, although, you know, it's a little quick for RPGN going from 3 to 6, and I'm sure there's ATN in the background, but, you know, I would still be worried of RPGN, and that's where some of those pending serologies come in with the ANCA and I guess ASO. If he didn't have a strep throat, but, you know, down that path of infection-related GN and other causes of RPGN, I think you have to still treat it as such, especially with the lack of other, you know, classic features of TMA. And again, the TMA, unless it's very chronic, to try to explain that proteinuria. So I'll say, you know, there'll be some ATN, and, you know, I'll go with, just to be different, and maybe I'll be wrong, is just he'll have maybe a crescentic necrotizing GN, and then we'll see what the serology shows to kind of clinically correlate it.
Let me ask Bill a question. I mean, you put your TMA pretty high in there, and didn't spend as much time discussing vasculitis as Dr. Baxi did. Would you have started on steroids empirically as we did?
Well, I will tell you, when I was reading the history, I was surprised he got started on steroids. But then I looked down at his urine findings, and I would have absolutely done that. Just, you know, you can't wait on an RPGN. And if it's in the differential, then you should empirically treat until you can get the biopsy. So the urine is what really did it for me, though, as opposed to his clinical presentation.
No, that's a good point. I mean, these patients that have, you know, even though IgA vasculitis is, IgA nephropathy is uncommon in African Americans, we've seen more than a few. And I've had my own patients who've come in with this kind of microscopic hematuria, terribly difficult to control hypertension and rapidly progressive renal insufficiency. And in fact, you know, they had IgA associated vasculitis. So yeah, I mean, you know, there are a lot of things that don't fit with thrombotic microangiopathy, as Bill's pointed out, and a lot, as Roger's alluding, it is kind of interesting. People haven't bid on the vasculitis thing as much as the thrombotic microangiopathy with the hypertension, but for sure you can get hypertension with vasculitis, and that fits here very nicely. And an IgA vasculitis would really fit nicely. I think, as we've talked about before, IgA is just so uncommon in African Americans, but it's got to be in that differential there somewhere. So any other points that you want to make, Roger, or anyone else wants to make?
I have started pulsing with 500 instead of 1 gram now, based on Liz Lightstone's most recent GlomCon.
Okay. And for those of us that didn't see it?
You know, she just, I would love to do a Liz Lightstone imitation, but I don't think, but she said, anybody that gives methylprednisolone at 1 gram should not be, you know, practicing anymore or something. She said something very dramatic like that. And honestly, there isn't great data on how to pulse and how much we should give when we pulse. But
I was going to say, is there any data? I mean,
she went over a little bit in the GlomCon, which was quite nice, and so showed that there's a decent responses to 500 or even 250 in some of the, mostly it was lupus that she was looking at.
And the concern that she had over 1,000 as opposed to 500 was what? Arrhythmias, aseptic necrosis? I mean, what did she use as a reason?
Yeah, just the overall side effects of steroids and acutely hypertension and things like that. Just high dose steroids.
Okay. All right. Who's going to read the biopsy, Roger? Rodby, that is.
All right. The spin of the new wheel.
What happened to the sound?
Gone.
Faraz. Oh man, wish we could spotlight into all the first-year fellows as that wheel was spinning. Faraz, give me a second here. I'm going to make you co-host, and then you'll be able to unmute yourself, and then I'll give you control.
Yay. Thanks. Okay, so we've got a trichrome stain of 1 core. There's a lot of light blue material here and around here. This area, I'm not sure if this is actually maybe two separate cores, and this is cortex. I don't know.
It looks like it's
I
bent.
mean, it's fragmented a little bit in the middle, but it looks
Okay.
like it's all cortex. I see glomeruli throughout.
Yeah.
Okay. And
Yeah, so how much fibrosis do you see? Mild, moderate, severe?
This would be more moderate to severe, probably closer to severe. I would say like 60-70%.
Yeah. It's extensive. I mean, we do see some islands of healthy tubules tightly packed, but it's pretty extensive fibrosis. I estimate in the entire biopsy about 75 to 90%.
Okay.
If I can make a point about this core, you see glomeruli at both ends, not in the middle. I think they actually went, transverse enough that they went from cortex to medulla back to cortex. It's a really nice sample.
Truly the lower pole.
Okay. So next slide here, we've got a glomerulus here on the bottom, a little towards the middle to the left. It's, it looks shrunken, it looks small. There's some tubules to the left of it, but a lot of, there's some edema surrounding it. There's a lot of cellular material, but
So Faraz,
the main focus is the arterial.
Well, before we get to that, I mean, we have a medium power HME, so.
Oh, sorry. Yes.
Yeah. I mean, we have a few glomeruli here. Probably the one on the left at 9 o'clock.
Mm-hmm.
Some open loops, but the other two are underperfused. We would call that, ischemic.
Mm-hmm.
Yeah, we don't see wide open lumens. And then the tubules next to that are atrophic and scarred. You can see them broken down, and then that pink material's interstitial fibrosis surrounding them.
Okay.
So this is all pretty extensively scarred, what we see here. And then now, go on to what we see there in the middle.
Yeah, so that's an arterial with like onion skinning, right?
Yeah, so an arterial is very small. So this is an interlobular artery.
Okay.
Yeah, and we see concentric laminations of fibrosis, giving it an onion skin appearance. And I think on the next slide, we'll have a higher power than that.
Okay.
Yeah, so point to where you think the lumen, what's left of the lumen. Yeah.
Yep.
Yeah, like right there.
A little pinpoint lumen, nearly entirely occluded. And then how about those tubules below it?
Just like you were describing earlier, they look atrophied. They're small. I don't see any material or debris within the lumens, but there's a lot of fibrosis surrounding them.
Right. Yeah. And then you got a couple of gloms here. That one in the bottom right. We in this setting we say it's kind of ischemic or bloodless.
Okay.
It's not getting perfused due to the poor perfusion.
Okay.
David, that it really is striking how you don't see any open lumens, but yet you'd think if it was ischemic, glomerulus might be a little, shrunken a little bit. I mean, how do we know that?
I think it is shrunken. I mean, compared to the one above it, and we'll see on the other stains, that better highlights the glomerular basement membrane, and we'll see more of that.
But I mean, to that fact, I mean, when we talk about this, because it comes up, frequently, when they're shrunken, we usually talk about the fact you see more of kind of Bowman space, and these, everything seems to be collapsed down, if you will.
Right. Yeah, we have more. Some more coming. Okay.
So this is higher power. Oh, sorry. Go ahead.
Yeah. What stain is this for us?
This is PAS.
Yeah.
So this will show like basement membranes really well. So yeah, you have the glomerulus on the right. It has a few open loops around the periphery. And it doesn't look like it's shrunken down like the others did as much.
Yeah, most of the loops are open here. I don't see any thrombi. Actually, if you go to, it's subtle, if you go to the capillary wall, yeah, it's just above that where you were. Yeah, you can see a little remodeling. That's a mesangial area, but at 9 o'clock, yeah, right there, you could see a little double contouring. You see that in chronic TMA.
But some of these capillary walls look actually pretty prominent. You know, we've talked about membranous in the past. I mean, it's not as if this guy couldn't have had a couple of things going on at once. But the PAS in some of these capillary, I mean, the PAS makes these, to me at least, makes these capillary walls look fairly prominent.
Yeah. And then, and then what do we have there for us again? Yeah, the onion skinning.
Yeah, that's it's still an artery, right?
Yes, and then the little arterioles coming off of it to the right. Yeah.
Okay.
Yeah.
And then you've got a tubule down right below it. It's lost its brush border. Its epithelium's thin, so there's some ATN there, I think. And then there's more tubules to the left that are shrunken, atrophic.
Yep.
And there's a couple. There's this one small one that has a little bit of debris in it.
Right. Those are atrophic and scarred. Okay. Good.
All right.
And this is high power H&E again. Is that an arterial with a thrombus?
Good for you. Yeah.
Okay. And then right above it, I don't know what all this like cellular material is.
What kind of cells do you think those are? Yeah. Yeah.
Are those like mitotic figures?
No, they're
those look like polys.
Yep.
WBCs. Okay.
No, Malik, they're not giant cells. Those are neutrophils.
Neutrophils, yeah. Sorry. Interstitial edema.
White cell cast.
White cell cast. Okay.
Yeah.
So David, over to the left of the one arterial that's got a thrombus in it. That's another artery.
Yeah.
And it's got hyalinosis in the walls.
Yeah, there's some we call that myxoid. This more of an acute change. We don't have the onion skinning yet. It's kind of myxoid intimal thickening.
What about the vessel just below it, to the left and below? Right? Yeah. Is that same
hyalinosis,
thing, or is that hyaline as well?
Yeah, hyalinosis. And the interstitium is very fibrotic. Okay.
Yep.
So we've got another high power H&E. We have another arterial. This one looks more like hyalinosis instead of the onion skinning.
Yep.
Good. Yeah. And to what degree?
That's probably like the lumen is probably 10% of what it would probably be if it didn't have.
Yeah, right. So severe hyalinosis. Yeah. Another chronic change. This has been going on for some time.
And then you've got tubules surrounding it. They all look atrophied. There's a lot of interstitial fibrosis. I don't know what at 9 o'clock this pink material is. That another?
That's a tubular cast.
With a cast.
Yeah. Okay. Good. Yeah. Next slide.
This is high power PAS again, and you see the basement membranes. There's only a couple open loops, and you see a prominent Bowman space. So it looks like this is a shrunken glom.
Yeah, ischemic, very, very wrinkled.
This almost looks lobular to some degree. I don't know if that's kind of overreading it, but
I think because you have some segmental collapse in areas.
Yeah.
Yeah.
And then the surrounding interstitium, you have fibrosis and tubular atrophy, again, with some thinned out tubules up at the top that have lost their brush borders, so some ATN as well.
Yeah. Okay.
there you
This
go.
is a Jones stain, high power, and you can see a very ischemic glom with a big Bowman space. Is this like a crescent?
No.
It's not a crescent.
No, that's that proteinaceous material, or,
Okay.
in the urinary space. Yeah, the glom is ischemic and wrinkled and shrunken down.
Look at those vessels. Exactly. Look at those vessels you're pointing to right there. What do you think those are, Roz?
Those are arterioles.
Yeah.
Does the one on the left have a thrombus in that one too, or no?
It may. It's hard to appreciate that on the PS stain, on the silver stain, but it likely is.
But they're it looks like hyalinosis in the walls there as well. I mean, this is what I was waiting to see, actually. I mean, this goes along with this guy's had hypertension for a long time, I would think. I assume, David, most of his vessels look like this.
Yeah.
And for us, you can kind of see, if you go back, I'm sorry, David, that, it almost it almost looks like it could be hypercellular, but it's really kind of, it's not. It's just because everything's so shrunken down, kind of cells that are there make it appear that there'd be some mesangial hypercellular or not. So don't get confused by that.
Okay.
Well, you're seeing, you're right, Bill. You're seeing the podocytes, basically, the visceral epithelial cells.
Yeah.
So
The nuclei are all around.
That tubular debris on the left. I see some chat about RBC casts. Malek, on the Jones stain, it's not a good way to see gas. That's probably tubular debris, ATN. We would need the H&E to see RBC.
Wow. It's probably the best looking glom in the whole biopsy.
Yeah.
So we've got another high power PAS. Yeah, this is a pretty good looking one. Lots of open loops. The mesangium looks pretty good. It doesn't look, maybe there's a couple places where it's a little hypercellular. But and a couple places where it might look a little expanded, but otherwise looks pretty good. The surrounding tubules, is that an arterial where the mouse is right now?
That's a thickened atrophic tubule, thickened basement membrane. Yeah.
Okay.
Yeah. So 1/3 of the glomeruli showed that ischemic changes like we've seen, and then the other 2/3 looked healthy like this, without mesangiolysis, just a normal glomerulus.
Okay. And then the surrounding tubules, again, we see a lot of thinned out epithelium, loss of brush border. There's one up at the top that has a little bit of the brush border left directly above the glom at like 12 o'clock.
But even there, the basement membranes with that PAS are very thickened. So those are getting to be atrophic as well.
Yeah, in the top left. Yep.
Okay. So you have ATN going on.
Yep.
And then, yeah, more ATN, interstitial fibrosis in the tubules that you see in the middle. The ones up at the top right are more atrophic, collapsed.
Yep. Yeah, so in the ATN, we have the loss of brush borders, the epithelium's thinned out. Okay, good.
So IgG, IgG is negative staining.
Yeah. So there's no membranous nephropathy or anything else in the line.
So on low power EM, let's see, the blood space is up.
Yeah. How about point to the capillary lumen with the arrow?
So I'm going to say it's up at the top.
No, that's the urinary.
Is it the urinary space? Is it right in the middle then?
Right in the
They're really
crosshair,
small.
yeah.
Okay.
That's the capillary lumen. And so what do you kind of appreciate what's going on with this capillary loop?
It's very small.
Yeah. Yeah. And then notice the basement membrane is very wrinkled and it's kind of collapsed, much like we saw in the glomeruli.
Okay, yeah.
And actually go to the point at 4 o'clock. There's even some mesangial interpositioning. Yeah, we're getting some remodeling of the capillary wall as seen in chronic TMA. Yeah.
Okay.
All right, next.
EM higher power is the blood space, the capillary lumen on the bottom left.
Yeah, right there. You've got it's basically that's what's left of it right there.
Yeah.
So what's going, if you trace the basement membrane around, what do you see as you go up and around?
The foot processes are starting to get a little effaced.
Okay.
Um,
And what do you right where your pointer is, but there in that nucleus, what's going on? If you even go back, is the basement membrane nice and smooth, or is it wrinkled?
It's wrinkled.
Yep. And then do you see any kind of space between that and the nucleus?
Yeah.
Okay. And above the nucleus is probably new basement membrane. So
Okay.
You've got this fluff in here between the two, which is what you see with an ischemic glomerulus, which gives you the MPGN-like picture.
Okay.
Yep, exactly.
All right, next. So what's your diagnosis, Farad?
We saw like acute and chronic changes of TMA, changes from hypertension. So we see TMA, severe interstitial fibrosis and tubular atrophy with ATN.
Okay. So you have this, exactly, this onion skinning, this thrombotic microangiopathy, which is with evidence of, severe hypertensive changes, which are chronic as well as acute. Is there anything you want to know now after you see all of this?
Regarding what exactly?
The lab tests that were pending, right?
The scleroderma antibodies.
Yeah, the SL70. I mean, there's no evidence, as you pointed out, of any vasculitis. It doesn't look like, he's got post-strep. So my guess is the ANCA and the ASO are, negative, and then the urine and serum immunofixation. There's no evidence at all here of any kind of paraprotein-related renal disease. But while you see that onion skinning, as other people had pointed out in their differential, you definitely want to make sure scleroderma is not, one of the culprits here. So what was the SL70?
It was normal.
It was normal?
Yeah, it was negative, yeah.
All right, so.
Roger, did you happen to get a renin or an aldosterone?
We did not.
So Bill, how would you read this, and what would you do?
Well, again, the CBC, as I said from the beginning, I thought it was going to be a TMA, but the CBC was just so unremarkable. So I think Dr. Robbie just put in the chat that the platelets did not eventually fall. I usually see that, even a subtle fall. So it's hard to call it a TMA without the hemorrhagic involvement, but that's what we have on biopsy. We have a malignant hypertension chronically for sure in his heart, in his kidney, and he came in acutely hypertensive, which I think is part of the acute thrombosis too. So, the next question is whether this is a second hit type of issue, like he's got an underlying atypical HUS that he's heterozygote for, or even he's homozygous for, and this is his presentation of it, or whether it's just what's been classically called malignant hypertension, and he might improve with blood pressure control alone. I
Bill?
will probably get into it. Yep.
So
Sorry,
I
go
know
ahead.
this is your lecture field. So correct me if I'm wrong, and I probably usually am, but to me, a TMA is a pathologic finding that doesn't, I don't know that you always have to have those peripheral findings. I think of, this microangiopathic hemolytic anemia that often has a TMA, and the TMA is the pathology, and the microangiopathic hemolytic anemia can go along with the processes that cause it. But is it really to define a TMA? Do you really need those peripheral findings?
Well, no. So you can have a TMA, for example, with antiphospholipid antibody syndrome, and you don't have to have a microangiopathic hemolytic anemia or thrombocytopenia, or you can have it from, I don't know, one of a variety of other conditions. And TMA, just like you said, should be thought of like anemia. There's a causes of anemia. There's iron deficiency. There's thalassemia. There's, et cetera. Or TMA should be thought of kind of like you think about your MPGN. MPGN is a pattern of injury, and then we think about our causes of it. But it's pretty unusual to not have the MAHA and thrombocytopenia with this degree of, especially in the setting of malignant hypertension, if we're saying the malignant hypertension is the cause of the TMA.
Okay.
And so that's why I would at least get a complement pathway problem on him, as far as to see, send off the genetic analysis for the complement protein analysis. And if that's the case, we might want to think about something like eculizumab. Now, the company for Solaris does not suggest that you get that. That's not part of the recommendation. And that's partly because there are some complement pathway proteins that would not be tested for, and they say that you could still have that, and thus you still would need to give the drug. The problem with that is there's never been a very good trial of looking at blood pressure control alone versus eculizumab in somebody with malignant hypertension. And we've all seen anecdotally through our own practices how just control of the blood pressure alone can lead to a real optimization of the renal function over time. I had somebody who came in with a creatinine of 10 at one point. He wasn't quite ready for dialysis, but I put a fistula in him, and with blood pressure control 6 months later, he had an incredibly perfect fistula, of course, to use for dialysis, but his creatinine was 1.8. So I put the fistula in him way too early and erroneously, and all that improved him was control of his blood pressure alone.
So I know we probably have some slides at the end, and I don't want to use up all the time. But Bill, the guy had no immunofluorescence findings, right? No C3 or anything significant to that nature. His C3 level is normal. How do we kind of go from there to having a complement abnormality?
Yeah, and you're right, Steve. The recommendations are not to send that pathway problem, but since the literature is going the way of, especially in the patients who are African American, that there may be some sort of familial type atypical HUS, because there's such an African American predominance to this disease in these patients that come in, and they're young. I still suggest, again, not based on the guidelines, but I still suggest getting it. And if it is positive, then I would lean more towards using eculizumab, and if it's negative, I would lean against it.
Fair enough.
And just go.
In the last question, and then we'll let Roger go on with the rest of the presentation. But fair enough. But when you've got 85, 75, 80% of the kidney already scarred, interestingly, when most of them were ischemic more than it didn't. I don't know how many globally sclerotic ones were, but most of them did look ischemic, which means they're on their way out. Is there any threshold above which you would not, give, eculizumab or the membrane attack complex antibody?
Well, even if I thought the kidney was dead, I may end up doing it if there was still significant other organ involvement, such as we had in this patient with cardiac, and you don't want his next one to come in with a stroke. And so you may want to think about it just for systemic disease as opposed to renal.
So you're assuming that he might have thrombotic microangiopathy involving the heart as opposed to it being hypertensive changes alone?
Or both. Maybe it's an underlying pathway problem that his hypertension is accelerating, and it won't be controlled until we control both.
Fair enough. Actually, you brought up an interesting point. Was any antiphospholipid antibody type stuff looked for in him?
No.
Okay. All right, Roger, you want to let us know how things went and what you did?
While you're pulling that up, Roger, I would also say that these patients have such renin-mediated hypertension, usually a high renin, high aldo, that they're almost, I wouldn't say the word easy to control blood pressure because they're so high to begin with, but they're very, very easy to control with a little use of an ACE inhibitor or an ARB, as opposed to using 15 different other agents to try and get the blood pressure down. Often people are afraid to use an ACE inhibitor when you're in the situation with renal failure, but it really should be the first line agent here. And you can control them almost like fibromuscular dysplasia with just baby doses of ACEs or ARBs.
But you bring, I mean, I think Sam Salzberg's on here because I remember him being the first one to talk about this. But when you've got that kind of microvascular disease, it's almost like bilateral renal artery stenosis, and then you vasodilate the efferent or the efferent arterioles. Almost, GFR may drop right out on you. It's just something to keep in mind. All right, Raj, what do we have here?
Well, that the point about pharmacologic treatment is important, I think, and one thing to think about is the use of loop diuretics that a lot of times people might use, but it may just exacerbate the situation because it stimulates potent stimulation of the renin-aldosterone system. And that's the problem, as Bill brought up very early in this discussion. That's the problem with this, is that you get an ischemic glomerulus, it clamps down, further ischemia, more renin release, more aldosterone, more angiotensin II release, and it just becomes a vicious cycle. And that's what people think changes you from, 160 over 80 without renal failure to 240 over 180 with renal failure. And so diuretics need to be avoided, that's for sure. Certainly if it's scleroderma, that's by far the ACEs and the RAS inhibition is the way to go. So, you do need some nuances. And we have seen occasionally a scleroderma patient present like this without enough skin findings. And we went and checked the SC70 and sure enough, it was positive. And then you go back and look at the fingers and there's a little bit of evidence, at least to a nephrologist, maybe more to a rheumatologist. So here's our story. We, you can see here, we pulsed him fairly early when we saw the hematuria. We had the same exact discussion in the conference room. Well, what about this blood? Is that too much? Maybe we don't want to wait. So So I typically, as Bill said, would pulse them. We gave them a gram of solumedrol or whatever it is.
Methylprednisolone.
Yes, methylprednisolone. Yes, exactly. And I think he's right, though. I think we used too much. Regardless. And then we put him on 3 days, then we put him on oral prednisone. And it took a while to get the renal biopsy because it was the holiday weekend. We did the renal biopsy. It started leveling off. It took us a couple days to get it back. And he was actually getting a little bit better by then. I'm not sure why his creatinine shot up again there, but it's been continuing to come down. This was as of 2 days ago. And so I don't know where he's going to level off. We don't know where he started. Remember, his renal ultrasound showed normal sized kidneys without echogenicity. So he may come back to a very reasonable level. The amazing thing about these cases is how much better they do get despite very severe pathology. We've seen people come off dialysis and end up with creatinines of 2, even though they were on dialysis for 6 and 8 weeks at times. It's not a common thing, but we have seen it. So you really can't predict exactly what's going to go on, what remodeling will occur. Yes, he did have a lot of chronic disease. I don't think he's going to get down to a creatinine of 1, but we'll see. Right now he's around 3 where he came in, and he's still on the down. So it'll be interesting to see. He was never oliguric, which is also interesting. So I want to talk about just really quickly malignant hypertension, because Dr. Corbett played the perfect straight man and gave us to define malignant hypertension as a number. And I always try to stress to people that it's not a number, it's a physiology, it's a symptom, because this is the autoregulatory curve, and it tells you that over a wide range of mean arterial pressures, renal perfusion remains the same. At some point it drops below that you can't dilate enough and you'll drop your pressure, and that can give you initially pre-renal renal failure and eventually ischemic ATN. And then there's a level above which you get that the blood pressure then gets transmitted into the capillary bed. And that to me is the definition of malignant hypertension, is when the blood pressure gets transmitted in the capillary bed. So where your autoregulatory curve sits really depends on what you're used to. And we have hypertensive patients that shifted way to the right, and we've got pregnant women that shifted way to the left, and they can get papilledema and hemorrhage and cerebral edema at 140 systolic. So that's why I don't like a number, and I like to stress more of a physiology. So just to remember, because we never see this, because we're not looking, and be that as it may, here's the signs of papilledema. It's, people talk about it. It's not that easy a thing to see, because you have to be really good at looking at the eye. But the one thing I remember the most is the lack of the disc margin there. And there's a very good example on the left of how good that disc margin is here and how blurry it is here. There's other findings, but I don't know that I'd be able to tell this venous engorgement from this retinal vein, or I might be able to see some hemorrhage, but certainly the disc hyperemia and the lack of the margin is really what I'd be looking for.
Plus,
So
you have
that's
to have
what
an
happens.
ophthalmoscope.
Well, you have to have an ophthalmoscope. The other thing so what I'm saying here is that this is evidence of malignant hypertension because now it's because this pressure has been transmitted to these capillaries. They're probably transmitted to every capillary, but the eyes and the kidneys of the brain are very sensitive to be able to look at, sensitive physiologically and very easy to look at. Kidneys you're looking at, of course, through the renal function, and the brain through symptoms. And of course, when you start having, microthrombi and blood's trying to force itself through occluded vessels, either markedly occluded from onion skinning or more likely, thrombosis, you end up seeing schistocytes. And as was pointed out, we didn't see any of these here. I reached out to Dr. Bacris that week and I said, the case, and I said, how do you feel about specifically what I was asking Bill, lack of TMA peripherally as far as predicting TMA in the kidney for malignant hypertension? And he said it didn't bother him at all. He didn't think that would have ruled it out at all. And that's kind of been my experience, but again, it's if you don't look, you don't see it. But we did check the LDH and the haptoglobin, so he certainly wasn't doing that. This is a case, really quickly. It says a white labor, age 40, first noted spells of choking. Other symptoms were pain in the right lower part of the back. Significant findings on physical exam were enlarged heart and a gallop rhythm. Later progressive dyspnea developed. The patient previously had diphtheria. Sclerosis of the peripheral arteries was graded 3. Neuroretinitis, sclerosis of the retinal arteries, and exudates were present. The patient used coffee and tobacco. And here you can see on the left, the chronic onion skinning, so that we've described, and a little more of the acute damage here. And so anybody want to guess when this is from, what year?
1940.
Pretty close, 1933, JAMA. And it's interesting how they describe these cases. But the point is that we're talking about a disease that's almost 100 years old, being described physically and pathologically, and nothing much has changed.
So is this a pathology? In other words, is this an autopsy? Because in 1930s, renal biopsies, it wasn't like there were a lot being done.
No, I don't believe it was. It's a really good question, but they had 11 or 14 patients. I don't think they were all dead. No, I'm sure they weren't all dead. I looked.
Okay.
Yeah, good point. But it just tells you that, we're still seeing a disease that's 100 years old. And so, there's what we didn't really see here are some of the, the more malignant changes. So on the right here, this is fibrinoid necrosis. What I described to the medical students as the mechanisms of damage, immunologic and then barotrauma, and this is really a kind of a barotrauma injury. And on the right of this vessel here, you can see a blowout of this vessel. So this is presumably barotrauma fibrinoid necrosis of this blood vessel. We don't always see that. And here's an earlier vessel before it's completely occluded. And some of these are actually going to be schistocytes as they're damaged as they're going through. This was from KI. So what is the long-term survival of malignant hypertension? This is a nice article in Spain about 10 years ago in NDT. And it looked at 190 patients, 7 patients over 32 years. They said the incidence didn't really change over that time period. Again, indicating this is a disease that we're going to continue to see, I guess. And they defined malignant hypertension as hypertension. They said high blood pressure, but basically they had to have retinal changes. So kind of getting back to my point of organ evidence of organ damage, 85% at AKI, but there's 84% 5-year survival. But proteinuria was the greatest predictor of renal survival. So, you could see here if you had, this is on follow-up, you had less than half a gram, you had a great chance of recovery. But if you had a greater than 2 grams, it went way down. You're almost nobody had renal recovery after 5 is so-so, but 10 years, pretty much gone. So that's no big surprise. We know that proteinuria is a predictor of outcome in all renal diseases, but this is only 2 grams, greater than 2 grams. And it may also mean that there's more than going on than just hypertension. They may have a glomerulopathy or something else. What's interesting is that they had 15 patients go on dialysis, only 2 came off. And, I went back and tried to find an actual number on this to see what percent, and, probably, we don't really know we may know the numerator, we just often don't know the denominator. People report people coming off dialysis, but we don't know how many don't. And if you would have asked me, I would have said it's more than that. It's more than 10%. Or 8% or whatever it is here. But clearly I've seen, I think we've all seen it. We've seen scleroderma do the same thing. And the truth is, I mean, scleroderma pathologically is going to look just like malignant hypertension. It just becomes then a clinical diagnosis, perhaps with antibody or physical findings. But I think this guy does have, run-of-the-mill hypertensive and what we used to call malignant hypertension in the kidney. He had, we don't know how much of it's acute and chronic. Certainly he's got a big left ventricle. He's probably had hypertension for a while. His kidneys aren't that bad though in size, and he may recover more than we think. And, again, only time will tell. People can come off dialysis. He can certainly has room to improve. And he actually had a kind of a diuresis after a while, which maybe was an element of ATN. And then finally, this is another point I wanted to make. And this is our patient actually. And you can, Fraz pointed out how small the lumen is there. And I couldn't find the paper no matter how hard I looked, but it was a really nice description of some of the acute renal failure of these patients isn't from TMA. It's not ATN. It's just the fact that you acutely lower somebody's blood pressure so much, and they're so used to having a high blood pressure, and their arteries are so clamped down and so closed that suddenly you have no pressure head. Forget about dilating the efferent arteriole with an ACE inhibitor. You have no pressure head. And a lot of these patients then will just slowly open up. It's purely hemodynamic, and it's not even ATN. And I've seen this happen. A few days later, they start making more urine and they open up. And I've even seen a low urine sodium on them. So it clearly isn't acting like ATN. But I couldn't find the paper, but realize there's a lot of mechanisms of acute renal failure in here. I mean, his gloms aren't, we saw a lot of good looking gloms.
So is the paper you're looking for specific to this, or the whole paper, the New England Journal article about normotensive ATN?
It clearly wasn't that. It was clearly about renal failure in the setting of lowering blood pressure that isn't always ATN. It's just purely hemodynamic. Then the last thing really gets into it. Bill, actually, I was surprised how much he talked about it, because this is fairly new topic and fairly hot topic, and that is the coexistence of hypertensive urgency or emergency or malignant hypertension, I prefer to call it, and thrombotic microangiopathy associated with complement defects. And on the left here, there's somebody who's got thrombus going into the kidney. You can see an ischemic glomerulus. You can see the onion skinning here. And this patient had a complement deficiency in C3. And so they really suggested, as Bill was kind of saying, that maybe we should be looking at this a little bit more. And if somebody has hypertensive emergency, they got TMA on peripheral or kidney biopsy, which is really interesting, is making that distinction we're making. So he didn't have peripheral, but he had it on kidney. It's a secondary TMA. There's a lot of workup for that. And Bill's written that on quinine exposure alone, causing that. But then they suggest actually doing genetic screening. I wish this was easier to do. I think, this in the next 10 years, we're going to be doing genetic screening for a lot of diseases, and I think it will become available much more easy to get, just as ApoL1 is getting easier to get. But basically, then they break it down into a complement-mediated TMA, in which, that is probably the second hit. They've had it all along, but the hypertension is the second hit versus just plain hypertension without anything alone.
So are there any other factors in these patients, like low C3 or low C4 or anything on the biopsy that would be indicative of that, or it was just one of those things that you just have to look for it?
Well, I didn't read the paper close enough to go into all those. It basically went into, a whole number of complement abnormalities associated with this. So, I mean, I don't know. I certainly don't think that the lack of complement staining or low C3, we know that isn't always the case in these complement disorders. It helps if it's there, but I don't think it has to be there.
That's true. That's exactly what you just said is exactly right. It doesn't have to be there, which is why they're saying sometimes don't even test for it. But I think that's kind of I don't know.
But, as far as eculizumab, I would have, let's say he has persistent microangiopathy, that would make a better case, or persistent renal failure. But he clearly kind of got better fairly quickly. And I think that I'm not going to pursue that route, whether it's right or wrong.
No, some of these things are, the most common ones are complement factor 8. It's the alternate pathway that's all screwed up, and that's why C3, at least many times, is low. And increased upregulation of C3 production is what sets off the membrane attack complex. And I guess the question is, I know they're common ones, but that's not all of them, and there's a ton of these different defects.
And they're often heterozygote for it as well, and it won't come out until a second hit is there.
In 5 years, we may go back and look and be laughing at ourselves at calling this malignant hypertension. It might be C4,
sure,
C5, B9 disease or something. But
yeah.
we have what we have. I think we've come a long way, but we haven't really come that far, as I showed you, from 1933. So I guess that's it. Thanks, everybody. Thanks for joining us. We saw some new people today. We saw a fellowship program in there. I'm sorry I didn't call you out, give you a shout out, but thanks for joining us. We hope you enjoyed it. And please join our channel. Today's CME activity code is 481291. We'll be back next week. And everybody stay safe and away from the Capitol.